For olecranon fracture, Mayo classification: type 1 is undisplaced, type 2 is displaced fractures, type 3 is comminuted or oblique fractures. Type 1 can be managed by the plaster as undisplaced. Type 2 is displaced fracture, needs tension band wire or intermiddle fixation. Type 3 is one which needs plate as comminuted or oblique fractures. If osteoporotic at less than 50%, excision is one possibility. A principle of tension band wire is convert tensile forces into compression forces. Cannot be used in comminuted forces fractures as there is no axial stability. Incise the tricep epinurosis between the unconis and FCU. Stabilize oblique fracture first with interfragmented K wires. Drill hole 4 cm distal to the fracture site and 5 mm anterior to the posterior cortex. 18 gauge wire is used for cerclage. A K wire size should be 1.6 mm to pass as close to the joint as possible. A traumatic anterior interosseous nerve injury is possible because of protrusion of the wire tip beyond the anterior cortex. Should not be more than 1 cm. Intramedullary placement of wires result in proximal migration of K wires and gap appearance. Recent treatment, new treatments is ortho cord instead of cerclage wire, number 1. Number 2, intramedullary fixation if there is no comminution. Plate and screw construction for oblique fracture or Montigia fracture or comminuted fractures. Excision of tricep and advancement if less than 50% of joint involved. Tricep reattachment is by non-absorbable sutures. Symptomatic hardware is common.